Good evening to everyone and welcome to today's session. I hope your preparation is progressing bit by bit, step by step in a fully energetic way. Today's discussion is supposed to be with the other students where I ask them the questions and they participate in discussion, but somehow I could not, they could not be able to catch up with the evening schedule. So that's the reason without students and interactive participation, let us didactically review for you around 25 questions. It's going to be a very short session of common image-based questions in the NEET PG. So, शुरू करें? Yes, doctor. Now, what is this radiograph in a patient who is presenting with shortness of breath? This is one of the most sought out question in the NEET PG exam. Can you please punch whether the voice is loud and clear for everybody? Can you please punch? Could all of you could be able to hear clearly? Can you please punch? Yes. Now, here you are able to see the collapsed lung. These are the normal bronchovascular markings in the right lung. But here, there are no bronchovascular markings. Very good. Sarita rightly says pneumothorax is the important entity. So, a left-sided tension pneumothorax with a large, well-demarcated area which is devoid of any bronchovascular markings. And if you look at the trachea, the air shadow in the trachea, you can find that the area, the tracheal air shadow got drifted towards the right side is what you are able to see. So that is the reason one of the very common questions asked in the exam you need to remember is, what are the causes of tracheal deviation? Towards the lesion, away from lesion. Very often asked. So, any lung collapse or apical fibrosis or any pneumonectomy that lead to ipsilateral tracheal deviation. This is the favorite MCQ in the tomorrow's NEET PG, FMG, etc., etc. Now, yeah, Sunny, Sandeep, and many more who are all online. Yeah. And many more. So, tension pneumothorax, a massive pleural effusion, any large mass like thyroid, then the trachea become deviated to the away from the lesion is what you have to ultimately remember. Yeah. Good to see Kamlesh Yadav and many more who are all online. Now, what is a very important finding on this radiograph? Who is going to give me the correct answer? Shashank, Lakala, Dr. Reddy, and many more who are all online. So, what is your diagnosis in this given case? First of all, you are able to see the breast shadows. So, this must be a female patient. Then you are able to see classically the diaphragm which is lifted up. So there is a atelectasis of the right lower lobe on the radiograph. Tomorrow's NEET PG exam or AIMS exam, this is one of the favorite question of the examiner. Now, this is how a right upper lobe collapse typically looks like. So this is the right lung. So here upper lobe collapse in the form of an opacity it is presenting. And this is an example of right middle lobe collapse. How do you know that there is a middle lobe collapse? The right mid and lower zone, there is an opacification which is quite often very subtle. Normally on the right lung you expect a horizontal fissure, but the horizontal fissure which you are expecting in the right lung is no more visible, which is a very important indication that the right middle lobe got collapsed. If you take a lordotic view, then you can be able to identify the displaced fissure. And there is an obscuration of the right heart border. So these are all the important indications that there is a right middle lobe collapse is what you need to emphatically remember. Now my question to all of you. This question is going to come in tomorrow's AIMS exam. You will be given a radiograph like this, a CT picture. Who is going to give me the correct answer? Shashank, Lakala, Kamlesh, Dr. Reddy, and many more who are all online. Shashank is proposing bronchiectasis. Excellent, doctor, excellent. So what you are able to see are the dilated bronchi, bronchiectasis, and the ring shadows that they form, which is very classical. And also the white arrows are outlining the tram tracking. Tram tracking means typically you have tram track in Kolkata. The city train runs on a tram track. So you are able to see the tram tracking, which is here also you can see the tram tracking, which is classical of those dilated bronchi in case of the bronchiectasis. Now, what is your diagnosis of this radiograph? And which drug can cause it? Who is going to give me the correct answer? What is the diagnosis and which drug can cause it? Very good to see 22 online students. So nowadays it is very easy, doctor, for running a live session. Earlier we used to set up a open broadcasting software, OBS and all that. Is very clumsy. The StreamYard is very easy. Into this, a lot of students also can join. And that entire Hangout on the air can be live broadcasted onto the YouTube. So that is the reason, if you feel that you want to sit and discuss with Dr. Murali Bharadwaj, please give a call 9000868356 and tell our helpline, hey, please include me to join the live challenge. I will send you around 100 MCQs. So you quickly solve the 100 MCQs and join the live discussion, which can be viewed by everybody else across the country. And खेलते खेलते हम खत्म करेंगे MCQ revision. So, but the only thing is, pan India, your other classmates, study mates will be able to view you in the live broadcast, and that gives an inspiration for you to prepare for the class. Honestly, I used to be not a very good student, but because I have to teach the students, I need to do revision for the entrance going students. I myself was entrance going. That gave me inspiration to read every day. So we should find some reason to read every day. And that will be the group discussion sessions with Dr. Murali Bharadwaj, live hangout on air on the YouTube channel of Online MBBS. Please tell your friends also. Right? Now, this is classically pulmonary fibrosis. Very good. Dr. Reddy is right. So, emitter bleomycin. Very good. Shashank Lakala rightly says, bleomycin, you should think of pulmonary fibrosis. Now, doctor, what are you seeing on this radiograph? And what is your diagnosis? Punch your answer, doctor. Let me see how many of you will correctly answer. 1 minute, I'll just get some water. Who is going to give me the answer? There is one classical finding, if you have observed it. What is the classical finding? I gave you a very good clue. Who is going to give me the answer? Same radiograph, ditto will come in the tomorrow's AIMS exam. What is going to be your answer? Yes. I already gave the clue, Dr. Reddy. This looks abnormal. What is this? No, this is not boot-shaped. Sarita, clean ball. Okay, this patient undergone a blunt thoracic trauma and now presenting with shortness of breath. Another clue. He has undergone thoracic trauma and presented with dyspnea and hypotension with this. What will be your answer? Very important clue I gave. Right? The patient is presenting with dyspnea and hypotension. Now tell me, what is your answer? Yes? So, can't you see the widening of mediastinum? This is called widening of mediastinum. Very good. Sarita Jindabad. So, widening of mediastinum, which is indicative of a transverse cut of the aorta because of the trauma. So, any penetrating trauma of the ascending aorta or a aortic aneurysmal rupture, any of them can lead to the development of this kind of an appearance, is what you need to basically remember. Now, a patient presented with this clinical finding. With abdominal pain. Okay, one more clue. What is the name of this clinical sign? Who is going to give me the correct answer? Come on, punch it. So, there are totally 5,000 image-based questions, doctor. You'll be 100% sure when you go to the exam. Excellent. Deepak Singh, Jindabad. Great Turner sign and Cullen's sign. Periumbilically, if there is a bleed, that's called Cullen's sign. In the flanks, whenever there is a bleeding, that is Great Turner sign. Now, what is the wrong statement about focused sonography for trauma? Focused sonography for trauma. Fast technique. What is wrong about it? Who is going to give me the correct answer? Focused sonography for trauma. So you should remember no, it has got a it has got a high specificity. Actually it has got high sensitivity. This is correct. It's not false. It should be true about. High sensitivity but a low specificity. That is a focused sonography for trauma. So if you look at the fast technique, this is the liver and this is the kidney. This view is called spleen and the kidney view. Got it? I'm sorry. It is not true. It is false only. False only. It has got a high specificity but a low sensitivity. That is more appropriate. Low sensitivity but a high specificity. So that is a correct statement. So that is the reason high sensitivity. 1 minute. I think we got mistaken. The correct thing should be true statement, not false. Okay. Now it should be true about fast, and high sensitivity should be the answer. That is the correct answer. Okay. Now, the third view is called the bladder view in focus in the fast technique. And this is under the xiphoid. It's called a pericardial view. Pericardial view. Sometimes in the liver kidney view, you are able to see this black stripe because there is a fluid in the Morrison's pouch. This is the fluid in the splenorenal recess. This is the fluid which is there in the pelvis. And this is the pericardial effusion fluid. So that's how the fast will be able to identify. Now give me your answer, doctor. You are being given an ECG. What is the dyselectrolytemia that you are seeing on this ECG? What is the dyselectrolytemia that you are seeing on this ECG? Who is going to give me the correct answer? Yes, doctor? Which dyselectrolytemia you are able to see? So, Sarita is proposing, Mayank is proposing hypokalemia. Santosh also. Santosh is saying hypocalcemia. Why? It is hypokalemia. So what are the classical features of hypokalemia? Flattening of the T wave, ST, depression, and presence of a U wave after the T wave. There is the T wave, following that any wave after T wave is called U wave. The presence of U wave. Now what is this dyselectrolytemia? Which ECG? What is the ECG finding in this dyselectrolytemia? Who is going to give me the correct answer? Yes, doctor. Who is going to give me the correct answer? Yes. Very good. Dr. Reddy, Shashank, everyone is proposing hyperkalemia. Absolutely. So you should remember peak T waves, wide QRS, ST depression. They are the early features of hyperkalemia. Once more, tell along with me. Peak T waves, wide QRS, ST depression. And disappearance of the T waves, heart block, presence of a sine wave. They are all the ominous features of hyperkalemia that suggest fatal arrhythmias and cardiac arrest. Now, this is another very favorite image-based MCQ, which is going to come in the tomorrow's AIMS exam. Be very sure of this. So, what is the length of this pharynx? Typically until this point. What is the length in centimeters? And if you take from the incisor tooth, what is the length until the esophagus enters into the diaphragm? What is this length? You want to give me two measurements, two lengths, which is the favorite question of the AIMS, image-based question. Who will answer me? Very good to see 29 online students. Excellent, doctor. Yes. Am I looking forward for some guesswork from you? Punch your answers. So any group discussion is meant to be more and more interactive, doctor. Very good. Sarita proposes 40 centimeters. Excellent. Shashank precisely says 15 to 20 and 20 to 30. 15 to 20 and 20 to 30. No, doctor. This length is 24 to 26 centimeters. And this length in case of men is 40, women is 38. And typically you have various constrictions of the esophagus while it is passing down. So the upper sphincter is at the level of the C6. Please don't forget. Aortic arch is at T4. And the lower sphincter is at T11. So these are the important numerics which you need to emphatically remember. Now, what is this barium picture talking to you, speaking to you? What is your diagnosis of this barium meal? Who is going to give me the correct answer? You can see this is esophagus. So how is esophagus? Esophagus is dilated and it is tapering down and it looks like a rat tail. Absolutely, Shashank. Echalasia, one of the favorite repeatedly asked image-based question in the NEET PG exam. dilated esophagus and smooth tapered gastroesophageal junction. So achalasia versus diffuse esophageal spasm. This is going to be one of the favorite questions of the examiner. Achalasia. There is a dysphagia, regurgitation of undigested food, severe halitosis, foul smell, weight loss, very important. Whenever a patient who has got dysphagia presents with weight loss, one possibility achalasia, another is esophageal carcinoma. And there is a cough and diffuse chest pain. In diffuse esophageal spasm, there is dysphagia and diffuse chest pain. Now, why do you get achalasia? Failure of the lower esophageal sphincter to relax while you are swallowing. And what are the causes for diffuse esophageal spasm, which lead to a corkscrew-like appearance for the esophagus? There is a swallow-induced large waves of esophageal contraction and a normal lower esophageal sphincter pressure. That is diffuse esophageal spasm. If you do barium, you see absence of the gastric bulb because typically nothing can enter into the stomach from the esophagus. Nothing can enter into the stomach from the esophagus. That's the reason normal gastric bubble, air bubble will not be seen. Whereas corkscrew appearance is a feature of the diffuse esophageal spasm. Nitroglycerin, nifedipine, surgery only if symptoms are severe and persistent is considered to be the management of choice. Whereas nitroglycerin, local botulinum toxin, balloon dilatation and Heller's myotomy in case of achalasia is what you should understand. Now, doctor, what is this radiograph talking to you, telling you? Give me your answer, doctor. Good to see Prasoon Vaidya. I was waiting for you, Dr. Prasoon. If you like to join a live discussion directly also you can, but it's okay. Yes. Multiple air fluid level, very good. What is it indicative of? What is your diagnosis, doctor? What is your diagnosis with this multiple air fluid level? Yes, good to see Aizul Islam. Aizul Islam, you are from which part of the country, doctor? Which city you belong to? So, Sarita says perforation. Perforation should bring air under diaphragm, Sarita. Very good. Deepak Singh, Jindabad. Small intestinal perforation. Absolutely right. So, dilated small bowel loops and air fluid levels, small bowel obstruction in this upright abdominal X-ray is what you need to remember. So, one small bowel obstruction with multiple air fluid levels is a standard stock image-based MCQ in the tomorrow's NEET PG and the AIMS exam. Now, doctor, what is this classical CT appearance? Who is going to give me the correct answer? Classical CT appearance. You should get so much practice of the image-based questions that tomorrow's NEET PG, FMG, AIMS exam, you should jump and answer. Very good. Yeah, good. Mayank is reminding about continued diaphragm sign. Deepak is saying Horrell sign. Give me the diagnosis, doctor. Give me the diagnosis. What led to that Horrelling? Very good. Horrell is okay. But what is causing that appearance? of the gut. Excellent. Prasoon rightly says mid-gut volvulus. Mid-gut volvulus classically. Now, what is this radiological sign, doctor? What is this radiological sign? Where you are able to see an inflated appearance. Inflated appearance. Excellent. A distended coffee bean shaped loop bowel, which is typical of sigmoid volvulus, Deepak Singh rightly says. Now, what is this classical radiological feature? What are you able to see here? What are you able to see here? Tomorrow's NEET PG exam, they are going to ask you straight away. So, doctor, I want to tell all of you, there are 20,000 MCQs we created and provided them as 200 section-wise tests on the Q scanner on onlinembbs.com. So please don't forget to subscribe to the Q scanner. Take the section test. Every day at least one section test containing 100 questions. After you answer the test, you will get the scoring. What topics you did right, wrong, everything, all that analysis will come. So that you will be knowing where to improve. That is very important, right? So you can give a call to 9000868-356, our helpline number, in order to get at a throwaway price subscription to onlinembbs.com video library, full scale 65 full scale grand test series along with discussion, and 20,000 MCQ Q scanner. All this you can get an access on onlinembbs.com. So this is called a apple core lesion. Apple core filling defect in the descending colon on the barium enema in a typical left-sided colon cancer is what you are able to see. Very good to see, sweetie Ebenezer. Now, what is this rule? What is the name of the rule in anal fistula called as? In the anal fistula called as. What is this rule in anal fistula called as? Who is going to give me the correct answer? In anal fistula. Shashank is saying Park's rule. Reddy is rightly saying. Dr. Reddy, you are from which part of the country? And what is your dream branch? Excellent. Goodsall's rule. So Goodsall's rule predicts the course of an anorectal fistula tract. You imagine a line which is passing across the anal canal, transverse anal canal. Very good. Dr. Reddy is our Telangana Reddy sir. Excellent. So, any fistula that is originating anterior to this anal line, it will have a straight tract. Whereas the fistulae which originate posterior to this anal line, it has got a curved tract. Curved tract. That's what you need to basically remember. Now, doctor, a patient presented with abdominal pain had a CT abdomen. What is your answer? Classical question. Image based. कल के NEET PG exam में जरूर आएगा. So in the next 6 months, I'm going to give you a practice of 5,000 image-based questions. So please tell your friends to first join our WhatsApp study group, our Telegram group. If you want to be included in our WhatsApp study group, please call 9000-868-356, our helpline number. Every time we are starting the class, you are going to have a notification in the WhatsApp and Telegram. Also click on the bell sign and get yourself subscribed. Tell your friends also. I am getting 50 best teachers in the country who are passionate to teach. I told them, please teach on our YouTube channel, onlinembbs.com YouTube channel. At least 10 hours you teach. Live online interactive broadcast every month. Almost 500 hours of live broadcast is going to happen freely on the YouTube channel of onlinembbs.com shortly. I will also be there, but a lot of our faculty will also be there. Almost 8 to 10 hours, some or the other teacher, the best teachers in the country, will be delivering the content. And you need not look around anywhere for getting the daily motivation to prepare. Just stick to youtube.com/onlinembbs. And don't forget to take our grand test series every Sunday. And subscribe to the Q scanner, 20,000 questions for that. That is going to make you to crack the NEET PG in flying colors. Okay, so that is the deal. So I'm handpicking 50 teachers, the best in the country, because nowadays to teach you don't need to go and hire a lecture gallery, pay costly lecture gallery fee and ask students to come. Not required. Have an internet, have a laptop, click, stream, and you have youtube.com/onlinembbs, where our students across the country are waiting to learn freely. Ideally, it should be free, right? So a lot of discussions are going to happen on this YouTube free channel. So please don't forget to be part of our Telegram and WhatsApp groups. So, doctor, I'm waiting if anybody can give. Ajbul Islam is from West Bengal. Very good, doctor. So, it is not renal stone, doctor. It is a stone in the appendix. So, classically, appendicolith with acute appendicitis. That is what you are able to see, right? Now, quickly shoot me an answer. Lateral border of the Hasselbalch triangle is formed by which structure? Sure. Good to see Rituraj after a long time. What are you doing, Ritu, nowadays? So lateral border of Hasselbalch triangle is formed by. Santosh is betting on external oblique. So doctor, don't forget, examiner mercilessly is going to test you on 3 triangles, which you should remember. The inferior border of the Hasselbalch is formed by inguinal ligament. Medial border is formed by the rectus abdominis, and lateral border is the inferior epigastric vessels. And typically, the direct inguinal hernia, why do you call it as direct? Because it passes through the Hasselbalch triangle, is what you need to remember. Now, who is going to answer this question? Triangle of Grinfeld is bounded superiorly by which structure? Come on. Punch your answer. Triangle of Grinfeld is bounded superiorly by which structure? Whatever. Rituraj, I'm so proud. MD anesthesia. The touch of Rituraj will make you to go into that heavenly pleasant layers of the anesthesia. So Rituraj, like all you guys, was sitting once upon a time, preparing for entrance, punching the answers. We kept on saying Ritu, 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 Ritu. And today, he's able to get a very decent seat. Anesthesia, emergency medicine, critical care. These are the things which define, honestly, a doctor. So, a good selection, Ritu. Keep up. Now, triangle of Grinfeld is also called superior lumbar triangle. It is bounded by 12th rib superiorly, internal oblique muscle anteriorly, and the floor is composed of quadratus lumbarum is what you need to remember. Now tell me the third triangle, doctor. Triangle of Petit is bound posteriorly by what? Triangle of Petit is bounded posteriorly by what? Who is going to give me the correct answer? Triangle of Petit is bounded posteriorly by which structure? Anybody would like to make a guess? Difficult guess. Triangle of Petit is called inferior lumbar triangle, posteriorly by latissimus dorsi, anteriorly by external oblique, and inferiorly by iliac crest. And its floor is formed by internal oblique and transverse abdominis, one of the favorite MCQ of the examiner. Now, when you look at the liver, what is this structure labeled A and this B? So basically, this is the diaphragm, this is the inferior vena cava, this is the coronary ligament, left triangular ligament, right triangular ligament, this is the gallbladder. Now I am asking, what is this structure and what is this structure? These two structures. Come on, punch your answers, doctor. So this is ligamentum teres, and this is the falciform ligament, is what you need to emphatically remember. So this is one of the favorite questions, doctor. Covenant's classification. Without that, there is no question paper. There is a hepatic vein. Once more, I want to tell you, if you analyze last 20 years AIIMS question bank, AIIMS PG medical entrance was conducted 20 into 2, 40 times in the last 20 years. In 40 times, at least 15 to 20 times, there is a question on covenants classification. Definitely they will ask the question. Okay? So, this is the hepatic vein. And from here, this is 4A, 2, 3, 4B. This is 6, this is 7, is what need to be remembered. Now, doc, that brings us to the end of this wonderful discussion, doctor. It is a little short, but sweet. And I thank all of you for taking your time with all the energy and participating in this session. Sweetie Ebenezer, Shashank, Dr. Reddy, good to see Rituraj, and many more. Once more, tomorrow they will join with a set of image-based questions tomorrow evening. And till then, read every day, read with perseverance, and don't forget to join and subscribe to 65 full-scale grant tests and discussions package of onlineMBBS.com. Good night and have a good time.